Well, thanks, Dr. Lemming, for the kind introduction. Thanks to all the organizers for making this happen. So I'm not going to go through all of melanoma in 30 minutes like Dr. Marshall did with colon cancer, so call it a failure of imagination, but we're mostly going to focus on the ASCO updates and hopefully get a window into what's going on in melanoma through that. So we'll start with just sort of the more traditional ordering here. We'll start with adjuvant and neoadjuvant therapy because a lot of really exciting things have been going on. As many of you who were at ASCO saw, we actually had a plenary in melanoma, which was pretty exciting with the Nadina study. So taking a step back and thinking about adjuvant and neoadjuvant therapy when we're thinking about immunotherapy. So this is a nice, fancy little schematic that some of the Netherlands group made, thinking about the contrast between adjuvant and neoadjuvant therapy. So when we're using adjuvant therapy, you have a situation where the surgeon removes the tumor, which we're very grateful to our surgery colleagues for doing that, and that certainly was really the only therapy for melanoma for a number of years. And then perhaps there's some micrometastatic disease left behind, perhaps not. And if there is, then hopefully the immunotherapy is able to recognize those cells that have gotten out, and the T cells are able to be generated against those cells and hopefully eliminate that micrometastatic disease. Now you contrast that to neoadjuvant immunotherapy, and at least my simple mind is able to kind of comprehend this pretty easily, where you have basically a bullseye, right? You've got a tumor in place, you've got something for the immune system to train on. The immune therapy is given, those T cells are generated, and then the surgeon does their job, cleans up the mess, and then any micrometastatic disease, there's already T cells that are recognized and are ready to go after that, any micrometastatic disease, even if it's still there. The immunotherapy may have already gotten rid of it. Now, this actually bears out in clinical data, so it's not just a fancy schematic. So they did something called T cell receptor sequencing in patients who got adjuvant or neoadjuvant immunotherapy. And I'm not going to go through the nitty-gritty scientific details here, but what you might be able to appreciate is that in the adjuvant setting, you have less T cell clones generated, and also the ones that you do generate in the lighter colors were often generated only after surgery. So this suggests that maybe these were T cells that were not even relevant to the tumor. They weren't there before surgery, so they weren't necessarily tumor specific. It's hard to know how relevant they were. On the other hand, with neoadjuvant, most of the T cell clones are these dark colors, which were T cells that were already present before surgery, so suggesting they were maybe T cells that recognized the tumor and were then able to be stimulated further to attack the tumor. Now again, T cell receptor sequencing is nice, but what does the actual clinical data look like? And so this is one really important study that I'll just briefly mention. It's not been updated in a little while, but this is the SWOG 1801 study, where actually they specifically tested this question. And again, most of these studies have to be powered really high to think about, what's the difference between a couple of doses before surgery versus just treatment after surgery. But really, this is a pretty small randomized phase 2 study, and what you can see is that 3 doses of neoadjuvant pembro followed by surgery followed by some more pembrolizumab compared to surgery followed by adjuvant therapy. You don't have to have a magnifying glass to see that difference of those curves. In fact, it's actually quite dramatic. It's a almost a 50% improvement in neoadjuvant therapy. So just a few doses of therapy before surgery has made that kind of difference. And so this study, along with the one I'll talk about, it really is kind of established neoadjuvant therapy as the standard of care for patients that have palpable stage 3 disease. And so really we've kind of moved towards that. But the other study that I'll mention that was updated, that was presented at ASCO this year, I think was a really landmark important study. It's been published in the New England Journal of Medicine. But let me go over this study with you quickly. So these were patients with stage 3 melanoma, had to have at least one lymph node involved. And these patients were randomized to 2 courses of ipi-nivo versus a therapeutic lymph node dissection, so which of course would have been the standard of care previously. You've got lymph nodes involved, of course you go to the surgeon and have them taken out. And so in this case, patients would receive 2 doses of ipi-nivo prior to that therapeutic lymph node dissection. That's kind of a weird dosing for those of you who sort of think about ipi-nivo dosing. It was a flat dose, but it was approximately correlated with ipi-1 nivo 3, which is the dose we often use in renal cell carcinoma, and which has really kind of become the standard for neoadjuvant melanoma treatment. It has approximately the same activity with less toxicity. And what was also really interesting in this surgery is that basically patients after this surgery, if they had a major pathologic response, which is defined as less than 10% of viable tumor cells in the surgical specimen, then went on to receive no further therapy other than follow-up. Okay, so that's a pretty big deal to give 2 doses of therapy and then that's it, no additional treatment. If patients have less than a major pathologic response, whether a partial response or no response at all, then they would go on to receive either nivolumab monotherapy if they were BRAF wild type, or dabrafenib and trametinib, which is another standard of care for adjuvant melanoma treatment. So really a little bit more of a precision oncology approach, again, not terribly sophisticated, but some sort of response-driven approach. So what did the data look like? Well, first, let me tell you about where the patients actually went, because of course one common objection and that of course should be thought about is, are these patients actually getting to surgery? Are they having toxicity? Are they progressing? Are they actually getting to surgery? And it turned out that this was a 400 or so patient study, and really the vast majority of patients went on to surgery. About 5% did not, and you could see the reasons there. A few had toxicity, 3 out of 212. A few had progression, and then 5 actually had surgery after the cutoff date, which probably meant they had some toxicities that sort of pushed them out past where this sort of technical study limit was. But really the vast majority of patients were able to go to surgery, and then of course that compares to the adjuvant group. So let's look at the actual results of this. And the event-free survival was the primary endpoint. Again, pretty dramatic results here, where you have the blue line is the neoadjuvant group compared to the red line, which is adjuvant. So a lot of patients progressing really early on the adjuvant therapy, and really quite a bit better outcome with the neoadjuvant therapy. So this is really cemented, I would say, 2 randomized studies now that show that neoadjuvant therapy is better than adjuvant only. So this is not just a fluke of a small randomized phase 2 study. We now have sort of 2 randomized studies that show this approach actually is a better approach. Now, how do the patients do as far as response rates? Well, this shows the pathologic response, where you have the green colors being either a complete pathologic response or a near pathologic response. And you can see actually that the central view showed a slightly higher pathologic response rate, 59%. So pretty impressive results there, where the majority of patients are responding to therapy. Now, what's also important to note is that the pathologic response didn't always correlate with the radiographic response. So if you had radiographically had a CR or a PR on your scans, the vast majority of those patients also had a pathologic major response as well. But some of the patients, as you can see, about half the patients with stable disease. So even if the scan didn't really show any change, or clinically you didn't really see a whole lot of change in these patients, about half of those patients still had a major pathologic response, all necrotic cells, all dead tissue when the patients had surgery. Progressive disease, obviously, maybe not surprisingly, not quite as good of outcomes there. And then what's really important, of course, is, okay, what does pathologic response actually mean? And so this is the data here, where you can see major and near major and I should say complete and near complete response. And the green lines, really did incredibly well. And the vast majority of those, I think only 1 patient had a distant recurrence. The rest were just local recurrences. So really, a pretty transformative results, and I think gives me confidence to use just the 2 doses of therapy and then monitor those patients that have that major pathologic response. But also gives the chance, as you can see, many of these patients, even without a response, with this response-directed therapy, were able to do pretty well as well. All right, so we'll move on to other therapies. And one I think that's really interesting to talk about quickly is some vaccine therapy. Now, for those of you who've been around a little while and have been in the melanoma space as well as other cancer space, vaccine studies have been a pretty dismal place to look, because there's basically been study after study after study that maybe shows a little bit of immune response, but then when you actually look at clinical data, it is dead negative. Negative study after negative study in the vaccine world. And there's at least some potential that maybe things are different this time around. Now we'll see, as I'll go through in just a second. So this was a study where basically patients that had high-risk disease were randomized to either pembrolizumab, adjuvant therapy, again this was sort of in the pre-neoadjuvant world that these studies were accrued, or pembrolizumab plus this mRNA vaccine. So this vaccine is actually a personalized vaccine where the patient had their tumor sequenced, and then it was basically a personalized vaccine was designed for up to 34 neoantigens in the patient's tumor. So basically, if they guessed wrong on one protein, well, they have 33 other chances to have the right immune target. So really a pretty interesting study design. In fact, these kinds of studies is part of the reason COVID vaccine was able to be generated so quickly, because as you can imagine, if you have to if you have to design a vaccine based on the individual patient's tumor, that has to go pretty fast, right? You can't be a year's process to develop that vaccine. And so what do the data look like? Well, this was the original presentation that looked at 18 months, and you can see, a pretty significant delta between the two groups. But then with updated data, that holds up pretty nicely, where you do have a pretty impressive delta between the two groups. Now, one thing I'll draw your attention to is if you see the number of patients in the pembrolizumab arm, only 50. So I think there's still a lot of wait and see kind of attitude toward this study. We'll really need to see the large phase 3 study. Supposedly that's almost completed accrual, or may have already completed accrual, as you might imagine, has gone really fast for accrual, many of which in Australia and some other countries. So I think, again, this is interesting to look at for melanoma, but I think this is potentially an important window into many other cancer types where potentially we'll see these vaccines if the results hold up. Now, it's a big if, and vaccine studies have been a pretty significant failure so far, so we'll have to see whether this actually does hold up. All right, so we'll move to some metastatic frontline setting. Of course, many of you know that the main standard of care at this point is either PD-1 plus CTLA-4 blockade or PD-1 plus LAG-3 blockade for the immunotherapy world. And then for patients who have really bad bulky disease, a lot of times we're using BRAF/MEK in some of those patients if they have a BRAF mutation. So of course, as all of us know, with oncologists, we like to, if we've got active drugs, we like to put them together and see what happens. And so this study was an attempt to basically combine PD-1, CTLA-4, and LAG-3 together. And this was kind of a strange study because it was actually, the patients were enrolled about 5 years ago, so we have prolonged follow-up, and this was the first time it was presented at ASCO this year. So these are patients who are immunotherapy naive, and we're getting this triplet regimen of PD-1 plus Ipi 1 milligram per kilogram plus relatlimab, which is the LAG-3 agent. Only 46 patients, so clearly can't draw definitive conclusions from a study like this, but certainly can potentially give us at least some possible signals. I've been wanting to see data from these kind of triplets for quite a while, and it is nice to see them. So what are the results? Well, for at least in the investigator review, you have a 59% response rate, which is pretty good. It's about the same as what we saw with the CheckMate 067 study with Ipi/Nivo alone, and actually that number went down a little bit when you're talking about central view. So it's hard to say whether this is a really promising option. There are some studies planned in the metastatic setting as well as in the neoadjuvant setting to see what kind of results that we get in those populations. So we'll see how these data hold up. Now, of course, if you're trying to block multiple immune checkpoints, the big question, of course, is what in the world toxicities are you going to be dealing with when you're doing this? And I'll get to toxicity in a second, but this also did show some pretty promising, I would say, overall activity where most patients did have tumor shrinkage. So we'll have to see how some of the data hold up as far as some of these stable disease patients and so forth. But going to toxicity, clearly we all know that Ipi/Nivo has more toxicities than single agent, and when you're throwing on another agent too, what kind of numbers are you getting? Well, in this study, you see basically 40 to 60%, depending if you're talking treatment related or not, AEs. So really not that different from Ipi/Nivo, at least Ipi/3/Nivo/1. So really kind of in a potentially tolerable range. One thing I would draw your attention to is there were 2 toxicity-related deaths. So 4% of the patients on the study had toxicity-related deaths. Now, of course, you're dealing with a small sample size, so we'll see how that holds up. But potentially promising option, but also potentially fairly toxic. And so, I think the jury's out on whether this is going to be an interesting regimen, but I think it's at least worth paying attention to. And I think, again, we'll see this in other tumor types too, where we have multiple immune checkpoints that might be active. When we're talking about sort of novel types of treatment that are worth paying attention to, both in the melanoma space as well as outside, I think TILs are pretty high on the list. So for those of you who are familiar with TILs, I think there's a slide here that kind of talks about the TIL process. So tumor-infiltrating lymphocytes is really a brand new therapy. There's a drug called lifileucel that was FDA approved earlier this year, and for melanoma, for patients who have failed available therapies. And this is a very complicated process, but at the same time, for patients who respond, it can be quite transformative. So the initial data from lifileucel showed about a 30% response rate, and the majority of those were quite durable. But on the other hand, it is quite logistically complicated, quite toxic, and quite difficult for patients. So one thing you can see, so the way these drugs are given, I'll get to the Pembro in just a second, but basically patients have non-myeloablative lymphodepleting chemotherapy. So basically similar regimens to what you would get with a stem cell transplant. So pretty intensive chemotherapy. Patients get the infusion of lifileucel, which is obtained, I should step back, which is obtained after a tumor is resected from the patient, sent to the company. The treatment is isolated, stimulated, and basically T cells are shipped back to the site. That process takes about 3 weeks. So then the patient gets chemotherapy, gets the infusion of the T cells, and then gets about 6 doses of high-dose IL-2. So again, some of you may remember back to the days when high-dose IL-2 was given, and maybe don't miss those days completely. I was a fellow, and I remember getting woken up at, it was basically 6 a.m., 2 p.m., 10 p.m. So if I was on call, I guess I wouldn't get woken up. I usually wasn't asleep, but I would be, setting my clock by that 10 o'clock and 6 o'clock call, and maybe some of you had similar experiences back in your training as well. So, like some sort of horror movie villain, it's back, right? So thankfully with this, it's only 6 doses and it's given every 12 hours. So it's a little bit more manageable. And, in many cases, patients might, be able to withhold a dose or two if they're getting sick. So that's one positive. But IL-2, unfortunately, with this study is back, or hopefully fortunately for patients, but a little bit unfortunately for logistics. So for this study, basically the sort of normal TIL process was, in addition to pembrolizumab, was given in patients that were frontline. And so what were the results? Well, first of all, toxicity really looked pretty similar to what you would expect with the TIL process itself. I did put this slide up just so you're able to see kind of what the toxicities are. Of course, as you might imagine, with lymphodepleting chemotherapy, all the patients get pretty significant cytopenias, as you'd expect, with an analogous stem cell transplant. Of course, most of the patients are getting fevers too because you're giving high-dose IL-2. So as you might remember, many of these patients get fevers and chills, and so of course they're also neutropenic. So you're having to cover them with antibiotics and rule out infection and so forth. The death rate in this is somewhere in the 1% to 2% range. So it's also something to think about. But really didn't see any sort of obvious toxicities. And the response were actually pretty good. I mean, you can look at this waterfall plot. Really, all patients had some tumor shrinkage, and the response rate technically was 65%. Definitely looks interesting and promising. I didn't put the survival curve on there. But I think it's something that it's really hard for me to imagine this moving to frontline with the sort of complications of, obtaining a tumor, sending it to the sample, to the company, and doing all the other adjunctive therapies. But certainly I think TILs are something that's going to be a real feature of treatment going forward. One thing I'll also briefly mention was the update for nivolumab plus relatlimab. So this is the PD-1 plus LAG-3 drug, again, only approved in melanoma, being studied in a lot of other tumor types. I think we all have kind of the feeling that nivo-rela is probably not quite as active as ipi-nivo, which is the other frontline regimen. But just to potentially challenge that narrative, this was the overall survival data from that study, and you actually see a p-value of less than 0.05 for the difference between overall survival between these two. And interestingly enough, we didn't even see that in CheckMate 067 looking at ipi-nivo versus nivo. So there's actually a potential delta there, and I think what might be partly going on is that many patients are getting nivo-rela and then also getting ipi-nivo if they progress. So it's just something to think about. So it's making me think that maybe nivo-rela is not too different from ipi-nivo in the frontline setting, at least for patients that don't have brain mets or other really bad prognostic features. Now, I'll briefly mention this study. I don't think this really affects the standard of care, but I think it speaks to one of the dilemmas that we have in medical oncology when we're thinking about, okay, I've got a patient with a BRAF mutation. Should I give them immunotherapy first, or should I give them targeted therapy first? And we know from the DREAMseq study that Dr. Atkins presented a number of years ago that ipi-nivo first, and then BRAF/MEK if they progress, is associated with better overall survival than the other order. So generally speaking, immune therapy first is the right answer, especially when you're talking about ipi-nivo, that we have randomized data for that. Well, what this study tried to do is basically to see, okay, what if we gave just a quick lead-in of BRAF/MEK and then switched over to immunotherapy? Would that potentially improve our outcomes? We know a lot of patients come in, they have big bulky tumors. It'd be nice to shrink those down, then switch over to immunotherapy. How would that work? And this was a study led by the French group. So you can see 12 weeks of Incobeni, which is kind of my BRAF/MEK inhibitor of choice, although others might disagree, and then Ipi/Nivo for 4 doses, and then nivolumab maintenance compared to more of the standard Ipi/Nivo. And so when you look at the survival curves, this is the PFS, quite dramatic by the French group there. So when you look at the 12-week outcomes, the BRAF/MEK lead-in looks great. Really almost no patients have progressed at that 12 weeks. Maybe not surprisingly, we'd expect BRAF/MEK to work longer than 12 weeks. But then you can see when you switch over to the Ipi/Nivo in the next little bit there, you can see those curves are starting to come together, and many of these patients are the ones who are probably going to progress anyway are still progressing. And then with further follow-up, those curves really come together. So you see, really no improvement and perhaps even slight detriment to using that BRAF/MEK lead-in. So there might be a possible group, of liver mets that might benefit from that Incobeni induction, but this is really not something that I'm necessarily using specifically, this particular regimen. So I think, and then overall survival actually, if anything, was actually slightly less. So, what do you do with that patient that comes in, has really bad disease, and you feel like the patient needs a response yesterday? They're in a lot of pain. They, maybe even in the hospital, they're sick enough, and you're just really worried that Ipi/Nivo is not going to give them a response. What I've been doing recently, actually, is and I talked to the MD Anderson folks, they've done it on about 20 people. I've done it on 3 or 4 at this point. What I kind of do now, it's kind of a weird regimen, but I'll start them on BRAF/MEK, and then after 2 to 4 months, I actually will give them a brief overlapping period where I'm giving all 4 drugs together. And boy, I was quite nervous about doing this at first because we know that BRAF/MEK plus Ipi causes a lot of colon perforations when you start them all together. But I think perhaps maybe when a patient's already used to BRAF/MEK, there's not quite that issue. So basically, what I tend to do is I overlap them for that first 3 weeks, the first cycle, and then I drop off the BRAF/MEK. And so far, so good. I've not had any, surprise toxicities or really bad toxicities. Again, these are the patients that have really bad disease. So it doesn't not necessarily the patients who are, asymptomatic and get started on BRAF/MEK, but the patients who you're worried if you take that BRAF/MEK off, they're going to be in real trouble really fast. So far, so good on that. Hopefully, we'll get that published at some point with a little bit larger number of patients. So finally, we'll move to the refractory setting in the last few minutes here. So again, this is a very small study of this agent. This is a drug that actually is an IL-2-free TIL product. So it's TILs, so tumor-infiltrating lymphocytes, like I mentioned earlier, but you don't have to give IL-2, which is nice. And I really just talk about this particular product to sort of mention that there are additional generations of TIL product that are going to be available at some point, most likely. So potentially IL-2 will not necessarily be in all of our future forever, but this is something that these kinds of approaches I think will be in our future for many different tumor types, not just melanoma. So this is a drug that basically is designed to, when acetazolamide, kind of a random drug that you give for altitude sickness or is a diuretic, is actually given, it'll actually turn the IL-15 on the TILs and cause the cytokine to be released, and that is able to free up and not require high-dose IL-2. The patients still have to get chemotherapy, but what was found in this study was that actually side effects seem to be less. I mean, you still have the sort of toxicities associated with chemotherapy, but you don't really see you don't see cytokine release, you don't see some of the IL-2 type side effects. You do see a little bit of liver inflammation, but really that's about it. No patients needed ICU. But what was encouraging here is that, really there seemed to be quite good activity in this kind of approach where you have a response rate of about 40%. And you also saw, many patients had tumor shrinkage as well. So again, this is not necessarily going to be the standard of care or anything like that, but I think it just sort of shows that there's a lot of innovation and a lot of drug development in this space, and stay tuned for it. Again, 4 out of 9 response evaluable patients responded. And then I think lastly, I was going to talk about RP1, which is a new oncolytic virus. Again, melanoma we've been lucky to have, some of the drug companies lead the way in some of the drug development in melanoma. And as many of you know, there's a drug called TVEC, or the full name's telimagene laroperavec, that's really an oncolytic virus. It's the only of its class that's approved in any cancer type, and we use it fairly routinely in melanoma. Well, this is kind of a next generation oncolytic virus that's sort of engineered to be more immunogenic. And the way these drugs work is they actually selectively infect tumor cells, recruit the immune system to attack the cancer, and then hopefully cause a response in the patient. And so this study was looking at RP1, which is that novel drug, plus nivolumab in patients who have already failed anti-PD-1 to see if you can reinvigorate the immune system and cause a response. And this was 140 patients, and the patients received injections for up to 8 cycles. So in many cases, as many of you who've used TVEC know, some of the lesions will melt away and then you're not able to continue to give it, and that was the case in this study as well. And here are the data where you see, a 31% response rate across all patients. You see responses in patients who have failed combination ipi-nivo. You see some responses in patients who have had primary resistance to anti-PD-1. So potentially promising data. I think the limitation to this is that you really kind of have to have an injectable lesion. So of course, many patients don't have a subcutaneous or cutaneous lesion, and it's not feasible always to work with our interventional radiology colleagues to get injections. Obviously, that's quite logistically complicated. And I think the data really are unclear whether you really see responses in patients that have high volume visceral disease. So even if somebody has, say, a subcutaneous metastasis, if their liver's full of mets, that's probably a group that I'm skeptical will really respond to an approach like this. But certainly we want to see more data as it comes. But to that point, you do see many times where you do have non-injected lesions respond. So that does give me some potential optimism that this might be a decent option for patients that, again, don't have huge volume of visceral disease. And with that, I would like to thank you for your time and attention, and happy to take any questions.
Thanks. That was an excellent review. My question, going back a little bit to Dr. Marshall's talk, he brought a lot of the precision medicine approach to GI cancers, and I think melanoma, I kind of feel like we've fallen a little bit behind in this. So we have gene expression profiling, which is used but not really been validated well in large independent studies. But the signal's there, right? It does show that there's some high-risk players in this space. And then we have ctDNA, which also you have some very interesting information about hazard ratios on recurrence, monitoring immunotherapy response. Why do you think there's been slow uptake in terms of this in clinical trials? And are you guys specifically looking at anything right now that incorporates this for your patients?
Yeah, it's a great question. Obviously we were early to BRAF mutations, but it hasn't progressed all that much beyond that. Yeah, it's a great point. So ctDNA and a lot of the adjuvant studies certainly shows worse outcomes. The problem is also, in Dr. Marshall's slide, it's only about 10% of patients or even less that will have positive ctDNA. So it's certainly helpful if you have it, but most of the patients who recur don't have positive ctDNA, at least at the initial check. Of course, if you continue to monitor, they'll likely turn positive, but of course, we also monitor them by scans, and so it's the age-old question of, does it matter to detect that recurrence, very slightly early. So I often will check ctDNA post-surgery to see. But I also don't know what to do with that information. It might push me a little bit more to use adjuvant. And of course, the patients who are ctDNA positive are probably the ones that you're going to be using adjuvant anyway because they're higher risk in general. But yeah, I think we still have a long way to go. I mean, there's certainly a lot of innovative things that are being done in the context of trials, whether it's microbiome profiling or gene expression profiling in the context of immunotherapy responses. Certainly there's interesting data for example, interferon gene signatures and using ipi-nivo and potentially even tailoring the dose of ipi-nivo to that. I think that's still pretty early, and there's not necessarily a lot of commercially available tests that can get that. So yeah, I think we do need to do a better job. I completely agree.
Thank you, Dr. Johnson. My name is Dr. Mufti Ahmad. I'm one of the medical oncologists in Cincinnati. I just had a question. How do you approach patients who have melanoma of unknown origin? And how does that fit into some of the clinical trials that you presented? Also, you mentioned like in a DINA study, one of the eligibility was palpable tumor or stage 3, but stage 3 is a very wide category. And how can you all lump it together into the clinical trial outcomes? I appreciate that.
Yeah, great question. To your first question, unknown primary, my general approach is to make sure they get a good skin exam. If it's something that suggests a particular primary site of origin, then certainly doing a little bit more work and looking there. Certainly if somebody has only a disease in their leg, it's maybe worth making sure they don't have a lesion under their toenail or something like that that's hiding. Generally speaking, though, the literature are pretty consistent that show that the molecular makeup and the clinical outcomes of those unknown primary melanomas are very similar to skin melanomas. And so, in general, I don't often do a super exhaustive search to look for the primary. I don't send them all for colonoscopies or, ENT evaluations. Not that it's wrong to do so or anything like that, but I personally don't do that. I just treat them like a cutaneous melanoma. We know that there's approximately 10 to 15% of melanomas where you never find the primary. It's most likely a skin lesion that somehow the immune system took care of, but some micrometastatic disease escaped. And so in those cases, I usually just treat them like a cutaneous melanoma, stage 3 or stage 4, depending on the situation, if it's a regional lymph node versus distant metastases. To your other question, as far as lumping stage 3 together, yeah, certainly agree. There's, I think, really two big picture categories. There's the micrometastatic stage 3 disease, and then there's the macrometastatic. So, of course, if you find the positive sentinel node at surgery, and that makes them stage 3, you, of course, don't have the option to give neoadjuvant therapy. Like it's, all the disease is out. You never really had a chance to do that. The other situation where you have macrometastatic disease, whether it's an in transit or a palpable lymph node or a node that you find on surveillance imaging, in the absence of more data, we do kind of lump them together because now, of course, it's worth risk stratifying those patients, of course. You can use the AJCC website and so forth and get a sense of, okay, what's the recurrence risk and so forth. The way I kind of treat these patients often is if they have a single lesion, non-bulky lesion, sometimes I'm using neoadjuvant pembrolizumab instead of ipi-nivo, whereas if they have multiple lymph nodes, bulky lymph nodes, I'm using ipi-nivo. That's my current approach. Ask me in a year, that might change. I think this is a very rapidly changing field. I think we may start integrating nivo-rela in that neoadjuvant setting. There's a small cohort of patients, and I'm sometimes doing that for patients with poor performance status but have bad disease that looks like it may be high risk of recurrence. So this is a rapidly changing field. I don't know that there's a right or wrong answer on which therapies to give. Like I said, I'm leaning a little more towards combination for most patients, but if it's a single node, single in transit, it may be reasonable to talk about single agent PD-1 in those patients.
Hi, Michael Bishop, University of Chicago, and very nice overview. I'm going to come back to the TIL things, and just as a cell therapist, so it's not really truly the conditioning regimen is not a transplant level. It's a non-myeloablative, similar to what we give with CAR T cells. As a matter of fact, most of these patients have very brisk hematopoietic recovery within about 7 days after infusion of their TILs. And with the IL-2, we dread's a strong word. We are very respective of IL-2, but in the confirmation study, patients received a median of 5.5 of their 6 doses, so the majority do get it, and people are looking at it to try to actually reduce the lymphodepleting chemotherapy. Now, Memorial, MD Anderson, et cetera, are looking to do that. So I just want to say, I don't want everybody to be scared to send their patients through this because it can do this. But I was interested in your statement you didn't see about this moving earlier to potentially frontline, because the Danish study actually kind of looked at that and demonstrated that it could be used in the frontline therapy. And there is actually data that the longer you wait to send these patients for TIL therapy, the efficacy drops off. So I was just, if we think that we can get patients to better responses, I'm just wondering why we would not do that.
Yeah, that's a great point. And yeah, I certainly didn't mean to be overly negative, from TIL. I totally agree. Many of us have great CAR T programs and cellular therapy programs that are able to manage these patients. And so, we certainly can, get the vast majority of these patients through therapy and with good quality of life. I've got a whole clinic full of patients that have done well and are doing well. So yeah, completely agree. This is something that is logistically complicated, but there's a lot of things in medicine we do that are logistically complicated, and we still do it, and it helps our patients. Yeah, so the Danish study looked at patients who had at least failed anti-PD-1, so at least had failed a frontline regimen. So I think my comment to that, I do think that it's very appropriate to get patients early in their course for TIL therapy. I guess the reason that I'm skeptical it'll ever sort of take front line would be because we see such good responses and long-term responses with traditional frontline I shouldn't say traditional, it's only 10 years old, frontline immunotherapy, where you see ipi-nivo, for example, with a 55% 10-year melanoma-specific survival. And so I'm just a little bit skeptical that we'll see improvement enough with the TIL process to sort of replace frontline ipi-nivo, for example. But I completely agree that I think early therapy is better. So in many cases, if for example, if a patient fails frontline immunotherapy, going straight to TIL. Now I may be wrong on that. It may turn out that.
The entire combination of ipi-nivo and TIL.
I think it's possible, whether ipi-nivo plus TIL could be a possibility. Yeah, I certainly think it's possible. I think especially if we, end up with a new generation of TIL where we're decreasing the lymphodepletion and we can get TILs from biopsies instead of, big surgeries and so forth. And of course, there's also patient-specific factors. Of course, at least at the moment, you can't give IL-2 to patients with poor performance status or decreased heart function or decreased lung function. And so, you're probably removing a third to a half of patients or brain mets just right off the bat at this moment. Now, again, future generations could be very different. Right. There is a little bit of data for brain mets. Yeah, exactly. So I think it's certainly possible. I just think, when we have a therapy that can cure half the patients with just an infusion, I think it's hard for me to imagine that the data are going to look that good. Now, I'd love to be wrong. If we're curing 80% of patients with a new generation TIL, then I'd be 100% on board with that. I think that's just maybe my current assessment. But yeah, great counterpoint. Absolutely.
Yeah. One comment I'd say on the TIL, the commercially approved TIL is ancient history. Rosenberg's. That's basically Steve Rosenberg's program, which has been around 20 years. I don't know, Mike. It's from when he started. That's not going to be the TIL world going forward. Tony Rebus actually did some studies looking at non-IL-2 stimulation with much less side effects. I think we're like he's inferring. I think this just opens the door for cellular therapy, and it's going to be modified and improved, and I'm not sure where it's going, but it's probably with its changeover in application in epithelial malignancies. I think we're going to see a whole explosion of that world eventually, but it's going to take some time and refinement.
Yeah, it's a great point. When you're thinking about already seeing, 20% response rate in cervical cancer, lung cancer, and so forth, future generation TIL, you could certainly imagine it, playing really big roles in some of these hard to treat cancers.
So as we're talking about TIL and we look at the patients that are currently being treated with it, whether it's the second and third line treatments or the patients that we're hoping might see it in frontline treatment, currently, the only places that it's really being available is these larger melanoma-specific academic facilities. There's been a significant decrease in the use of high-dose IL-2. And so when you start looking at being able to offer TIL to more and more melanoma patients, how are you seeing just the lack of experience with high-dose IL-2? And it's not even the experience with the physicians. It's the supportive staff, because we all know, whoever has used high-dose IL-2, that the people who are really doing all of the work are the nurses at the bedside. So how do you see this as impacting availability of TIL to more patients when we know most of the melanoma patients are being treated in the community, yet these are only being offered in the larger academic facilities?
Yeah, it's a great point. I think, making sure that there's awareness in the community that the patients can be referred and which centers are referring them or are doing the treatment. I think there is some institutional memory, certainly. You know, we have a number of our support staff, you know, certainly nurses and others that do have a little, you know, that have been around long enough to have used IL-2. I think the other positive is, you know, there are other syndromes and therapies that do cause toxicities that are in the IL-2 family, you know, cytokine release syndrome and so forth. So there is some, you know, sort of cross-discipline lessons that are learned that do apply, even if they're not one-to-one lessons. And then I think, of course, you know, making sure that there's protocols in place and that it's very clear as far as what to do when is really important. And I think that's, you know, I think that's, again, with something like CAR-T, a lot of those protocols are in place, and a lot of the staff is very used to, you know, sort of following those things, decision trees, and if this, do this, and so I think that's really important. And there are a number of sites that are, you know, are community sites that are larger places. You know, for example, in Nashville, Sarah Cannon's getting a CAR-T program, or getting a TIL program up and running as well. So there are larger community sites that are also giving it. So hopefully there will be a little bit more democratization of therapy.
So if I may ask this question, so TIL is actually very fascinating and a high future, right? But beyond TILs, are we paying attention to microenvironment of the tumor? Because we well know that microenvironment, of course, plays a huge role, right? And we see it across different cancers, and melanoma would be one example. So any opportunity to try to predict how soon we need to use TIL, because kind of standard you know, checkpoint inhibitors will not work. What is the research in that direction?
Yeah, I mean, that's a great point. You know, there are these, you know, sort of immune desert type tumor microenvironments that really don't seem to respond very well to immunotherapy. And so, you know, are those the patients that do need to go to TIL quickly? I think so far the problem is, you know, a lot of the biomarkers have enriched a population that won't respond to ipi-nivo, but you still, even in the sort of, you know, worst patients, you're still having 20 to 30% response rate to ipi-nivo. And so, you know, we're certainly not, you know, withholding therapy based on that. But certainly you could, you know, potentially use that as a biomarker to maybe push patients towards maybe frontline TIL or frontline triplet or other therapies. I think, you know, there's been a lot of interest in profiling the microenvironment, but many of the other sort of combination checkpoint or combination T-cell simulators have not done that well. You know, I mean, the most recent failure was the KeyVibe study, pembro plus the TIGIT inhibitor in adjuvant melanoma. That may not be the right place to use it and so forth, but, you know, a lot of these other sort of checkpoint T-cell simulators, macrophage depleters, et cetera, have not really worked out that well. Now, I'll be the first to admit those have mostly been used in an agnostic fashion. They've not been personalized to a particular tumor microenvironment. So you can certainly imagine a future where you know, have a more molecularly targeted set of immune therapies that we're using. The problem is, as was Dr. Marshall mentioned with colon cancer, you know, you're sort of slicing and dicing the pie further and further, and so getting to that point, I think, has been a challenge. But I do think that's most likely the way forward.
Hi, I'm Jen Ludden. I'm a lung cancer doc and a phase 1 investigator here at University of Cincinnati. I have a particular interest in oncolytics, so I'm glad you showed the RP1 data, which we participated here in Cincinnati. And as you said, the responses in uninjected lesions is rather modest. You know, it's kind of a pie-in-the-sky abscopal hope. But, you know, that was given with PD-1 inhibitor combination treatment. So I was just wondering if you think that the checkpoint inhibitor combination is required for the response in uninjected lesions, and how that influences your dosing and sequencing of TVEC in your own practice.
Yeah, I mean, I currently don't often give pembro with TVEC. Of course, the patients that I tend to give TVEC are the ones who mostly have cutaneous, subcutaneous disease. With that being said, you know, there is an ongoing SWOG study that we're waiting for data for pembro plus TVEC in the refractory setting. And the reason I don't tend to give it in the frontline setting is just because there was the large Amgen study that basically compared, which you probably know about, Pembro plus T-VEC versus Pembro alone, and it was a negative study. Now, it was a group of patients that had a lot of visceral disease and so forth, may not have been the right patient population to do that in. So I honestly don't know what the value of continuing the Nivo in that. With that being said, we have great data at this point. If you look at IPI post PD-1 versus IPI-NIVO plus PD-1, and IPI-NIVO plus PD-1 is a lot more active, 30+% response rate compared to like 10%. So there is something about continuing the PD-1 in some situations that really does add something. So I tend to lean towards, at least in melanoma, other tumor types, who knows, but kind of oftentimes lean towards continuing the PD-1, with drug X, whatever drug's being developed. I think it's a great point for the ASCO stuff. You do occasionally see it. I mean, I've had the odd patient here or there that, has some injectable disease, but also has visceral tumors. You give T-VEC alone and everything melts away, and it's, what's going on there. But it's certainly the exception, not the rule.
Great, thank you.
Doug, one thing, Dan Florid was inferring this, I think, with this self-free DNA. If you look at Dr. Marshall's presentation in colon and the response potential of the drugs available in colon versus the response potential of immunotherapy in melanoma, and melanoma being dramatically higher potential, what if you were following a patient and there's with cell-free DNA and they became positive? What's your thinking about the future of molecular relapse treatment?
Yeah, I don't usually tend to do that personally, just because it's one more thing on top of scans and so forth. Of course, it's not wrong to do it. It's totally reasonable to do it. I would certainly worry that patient's destined for a relapse. Of course, I would get a scan if they didn't have one. But yeah, I mean, I think that would certainly be a potential reason to think about treating them. But it would certainly be off-label and off without a lot of data. For better or for worse, we don't even have the kind of data that he was pointing to for molecularly positive relapses. We really have no idea what the outcomes for those molecularly positive patients are. But with that being said, I mean, I would lean towards treating them more just like an actual relapse and thinking about treating them systemically.
So in contrast, colon, the shed rate of DNA for melanoma is dramatically higher than colon. So like Dan's comment, you wonder why isn't that included in the prospective studies to answer the question.
Yeah, that's a great point. We should certainly think about that for sure.
Well, if we have no new questions, we're going to have a break, I think. We'll give everybody applause for Doug's presentation, which was excellent.